All right, let's dive into a medical condition that sounds like it was pulled straight from a Norse saga. Today, we're unraveling Dupuytren's contracture, but you might know it by its much cooler nickname, the Viking disease.
I mean, that name alone just grabs you, right? It makes you think of ancient warriors and some kind of genetic legacy passed down through the ages. But what it really is a modern medical puzzle that affects millions of people, slowly and quietly taking control of their hands.
And this picture, wow, it shows you exactly where this condition can end up. What might start as just a small, totally painless lump in your palm can eventually progress until your fingers are literally pulled inward permanently. Things you don't even think about, shaking someone's hand, pulling on a pair of gloves, or even just putting your hand flat on a table suddenly become a real challenge. So what's the official story? Well, it was first documented way back in 1831 by a French surgeon, Baron Guillaume Dupuytren. It's a chronic thing, a progressive disorder that messes with the connective tissue in your palm, what's called the palmar fascia. This tissue starts to thicken up and tighten, and it's that tightening that pulls the fingers, usually the ring and pinky fingers, down into that bent position. Okay, so that leads to the big question. Who actually gets this? And what's the deal with that Viking name? Let's take a look at who's most at risk.
So yeah, that nickname, it's not just for dramatic effect. The condition is way more common in people with roots in Northern Europe. We're talking places like Norway, Iceland, and the UK. This points to a really strong genetic link, one that seems to have traveled with populations for centuries, kind of like the Vikings themselves.
And get this, when we look at the gender split, it's pretty wild. Men are up to 7 times more likely to develop Dupuytren's than women. We don't totally understand why, but that is a huge statistical difference. Age is also a massive factor here. It almost always shows up after the age of 40, and the odds just keep climbing as you get older. In fact, it gets so common that up to 20% of men over 60, that's 1 out of every 5, might have some form of it. So, besides your ancestry, age, and gender, there are a few other things that can up the risk. Having a strong family history is a big one. But certain lifestyle factors, like smoking and heavy drinking, have also been linked to it. And so have other medical conditions, like diabetes and epilepsy. So we know who's at risk, but what is actually happening inside the hand to make it do this? Let's get into the biology of it and see how this all develops. It all starts right here, in something called the palmar fascia. Just think of it as this tough, fibrous layer right under the skin of your palm that helps keep things stable. In a healthy hand, it's nice and flexible. But with Dupuytren's, that tissue goes rogue and starts thickening and contracting. And this image lays out the journey perfectly. You can see it starts at stage A, with just a little firm lump, a nodule, in the palm. Then, over time, you get to stage B, where that lump starts to form a thick, ropey cord. And finally, you hit stage C. That cord tightens and shortens, and that's what physically pulls the finger down. Now, scientists have broken this process down into 3 main phases. First up is the proliferative phase. This is where special cells called fibroblasts start multiplying like crazy, and that's what forms those first nodules. Then comes the involutional phase. This is where everything changes. Those cells line up and contract, creating these tight cords. It's like someone is pulling on drawstrings inside your hand. And finally, you have the residual phase, where the process is done but the cords are left behind, holding the finger in that permanent bent position. So what's the tiny culprit driving this whole mess? At the molecular level, it seems to be a protein called TGF-beta. The best way to think of it as a master switch. In Dupuytren's, that switch gets stuck in the on position, and it just keeps telling the cells, make more tough tissue, tighten up, over and over again. So if your hand is being pulled in by these biological drawstrings, what can you actually do about it? Let's walk through the treatment options that are out there right now. First things first, doctors need a way to figure out how bad the situation is. One of the common ways they do this is with the Tubiana system you see here. It's pretty straightforward. It just classifies how severe the bend is based on the total angle. This grading system from 0 to 4 is super important because it helps them decide when it's time to step in and what to do. When it comes to treatment, there are basically 2 main roads you can go down. For the earlier stages, non-surgical options can work really well. We're talking about things like enzyme injections or even just using a needle to break up the cord. The recovery is way faster, but for more advanced cases, surgery to actually remove the diseased tissue is usually the go-to. It's a bigger deal with a longer recovery for sure, but the results are often more complete and last longer. But Last longer is a really tricky phrase when you're talking about Dupuytren's. This chart tells a big part of the story. Recurrence is a huge problem. With collagenase injections, the problem comes back in about 35 to 40% of people within just 5 years. And for the needle procedure, that number can shoot up to 85%. 85! This right here is the single biggest challenge with this disease. And that brings us to the final and honestly the most frustrating piece of the Dupuytren's puzzle. Why does it keep coming back? You know, part of the issue is that experts can't even seem to agree on what recurrence actually means. As this quote explains, different studies use different goalposts, which makes it super hard to compare how well different treatments are really working. Is it a recurrence if a tiny nodule comes back, or only if the finger bends again by a certain amount? Without a standard definition, the data is just messy. But here's the real kicker. The fundamental reason it returns is that all our current treatments are just managing symptoms. They get rid of the cord, they might dissolve it or cut it or remove it, but they don't do anything to stop the underlying biology that caused it. Those fibroblast cells that started the whole thing, they're still there, and they can just decide to start the whole process over again. And you can imagine what this means for patients. It creates this really difficult, chronic cycle. This isn't a one-and-done kind of fix. Managing Dupuytren's often means a lifetime of keeping an eye on it and, very possibly, going back for more treatments as the contractures return. That can be incredibly draining, both physically and mentally. Which leaves us with this final thought. The future of treating the Viking disease isn't just about getting better at cutting the cord. The real holy grail, the ultimate goal, has to be figuring out how to turn off that master switch, how to stop those cellular drawstrings from ever starting to pull in the first place. And that's where the next chapter of this story really needs to be written.